Very very bank very very president very very shot with them or shot with them very when joining you sono attati a tu okay Leo Yasa Yilia. So the presentation is just an initial thought about the roadmap for the Health Renaissance Initiative of NSODA. So it's an initial discussion to have your feedback so that we can have a document finalized that will guide us how to move forward. So the idea is the presentation, it follows this outline. It follows the outline that is in the document, because I first drafted a document, a Word document, on the roadmap of the Health Renaissance Initiative, which has an introduction. And in the introduction, we have the primary health care, the healthcare system in Cameroon, the healthcare system in South, and then we have some objectives of the initiative, and then the proposed interventions, then followed by a proposed approach, which is the NGO approach, which is something that we will be proposing for other initiatives too in other sectors. So why primary health care? The idea of primary health care started in Amata in 1978, and it was initially proposed with 8 components. The 8 components are the education on health problems, the effective supply and proper nutrition, maternal and child health care, safe water supply and basic sanitation, immunization, the treatment of local endemic diseases, and the treatment of common disease and injuries, as well as essential medicine. It was proposed, this approach was proposed, and then was adopted by, I think, almost all countries in Africa, and all other countries, especially developing countries, in the 1980s. Some countries succeeded, but some didn't implement it well. And in 2018, WHO called for the Astana conference, which was to redynamize the primary health care. And they tried to revive it and restrict it and call it a whole of society approach to health and well-being centered on the needs and preferences of individuals, families, and communities. Right. And it identified 3 components: a comprehensive range of services. Here they include promotive, preventive, curative, rehabilitative, and palliative for common diseases and injuries, and the systematically addressing broader determinants of health. This systematically addressing broader determinants of health was not in the primary, in the Amata, where here it shows that we must also look at other components that are outside the health, including nutrition, transport, water and sanitation, education, and housing. Then it also looked into how we have to empower individual families and communities. This component was in the Amata, the 3rd component, empowering individuals, families, and communities to control their health as self-carers, caregivers, co-designers of healthcare system. So I think it is similar, but what was added in Astana is just about systematically addressing the broader determinant of health and looking at from a broader perspective. The reason this approach is desirable is because it is effective. 50% of gains in reducing maternal and child mortality between 1990s and 2010 were due to factors outside the health system. And that's why they included that broader view of looking at health. And it is cheaper because it reduces the total health costs and improve efficiency by reducing hospital admissions. It covers 90% of healthcare. The rest of the 10% is actually tertiary healthcare, which is about really a very high level. It has wider benefits beyond the health sector, such as poverty reduction, hunger reduction, education, clean water and sanitation, climate change, and gender equality. It has broader benefits outside the healthcare system. Now, if we look at the Cameroon health sector strategy, it's identified two approaches to healthcare: the primary healthcare approach and the complex specialized care approach. So it says the primary healthcare approach, the impact will be on beneficiaries. And this has been proven. There is no need to demonstrate that. But we still need the 10%, we still need really specialized healthcare. That is the one provided by university teaching hospitals, for example. Central hospitals are much more specialized with many other complex examinations and specialists that may not be available at the primary healthcare level. So the Cameroon Healthcare Strategy 2016 to 2027 says that community action is expressed through public participation in healthcare finance, participation in representatives of communities and co-management, and then advocacy, communication, and social mobilization of civil societies, as well as services by community health workers. Then community initiatives for promotion of health. These are some of the things that are in the Cameroon Health Strategy. Just to say, this is in line with the national strategy of the healthcare system, and it is so far what has been proven to work in countries that have succeeded in actually driving mortality down. Examples are Rwanda, Ethiopia. They have really driven mortality down by using this strategy. And no other strategy has actually worked at the national level that is able to bring down maternal mortality or infant and child mortality than primary healthcare approach. Now, when you look at the health system in SO, this is the way the government categorized the health services. The category 1 is the university teaching hospitals. 2 is the central hospital. 3 is the regional hospital, like the one in Bamenda. And 4 are the district hospitals. Okay. According to the categories by the government, they consider that in SO, the DBH and Chisong are category 4. But I believe that they are more than category 4 because they have more services that can go to even be at the level of category 2, or at least minimum category 3. So, but according to the theoretical categorization, they are considered to be 4. So we do have, according to the government classification, 4 hospitals of category 4 in SO. This is the Jekiri Hospital, the Kumbu District Health Service, which is not really having the same level. The DBH is somewhere is not really having the same level. Then we do have category 3, which is the medicalized health centers of Jekiri, Kumbu, and the one in Biame, I was told, is closed. And then we have 289 integrated health centers. So it's estimated that the population so is about more than 140,000 people. That was before the crisis. Now we don't know how many people are there because many are moved. And it is divided into Kumbu West District and the Kumbu East District. So now, looking at what are the strengths and weaknesses of the health system in SO, I think one of the things that's important to look at is the excellent tertiary hospitals that we do have, the BBH and SHISO. Unfortunately, the crisis has had some negative impact on these services that we really had the advantage of having. But there are weaknesses like the suboptimal quality of services at the primary and secondary level. We go down to the integrated health centers. The services are not really up to standard. We do know that individuals and communities are not empowered to optimize their health. They don't participate in the management of these, like we see in real countries that these have succeeded in management of the health centers. They observe the health center. The population believe the health center is the government and that it is managed. They don't understand it is owned by them and that they should have a say about it, even about the recruitment and all that. That is still a long way and we are not yet there. Most of the payment is out of pocket. People do not have insurance, most people. There is a lot of ignorance and harmful social and cultural practices, communication and transport issues from some villages to hospitals is noted. And then we don't have enough resources in terms of human resources, medical supplies, infrastructure. So those are some of the weaknesses that we may try to see how to address them. The challenge is how to address them in our primary healthcare system. So the objective of the proposed objective of the Health Rennaisance initiative, the overall objective is to reduce premature mortality through prevention and provision of essential healthcare services. The premature, if we can, because there's a lot of premature death that occur, either due to the crisis or even before the crisis, that if we can reduce, and that will be really significant improvement. And so the specific objectives are, how do we do this? To build broad range of partnerships that will help us mobilize resources and technical know-how to build a solid primary healthcare and raise awareness to common health issues and promote behavioral change. And then explore ways to set up a system that reduces out-of-pocket payment. Then strengthen leadership and governance of the health health Rennaisance initiative, as well as the management of the health system, even in because we need to have a say in the management of it, and then ensure availability of quality essential health services to all persons. Then mainstream health promotion into other sectors. That is what the primary healthcare talked about, other sectors, mainstream. So that when we are talking about nutrition, we should also link it to health, sanitation, education, and housing, as well as culture and environment. We should link all these, even sport, we should link it to health and see how we can use those fora in order to promote health. So the interventions, I use an acronym people because I think it is people-centered approach. So which P stands for partnerships, E for empowering communities, O is other sectors, and P is paying for services, then L is leadership, and E is essential services. So we'll just look at some of these rapidly and then look at the approach, proposed approach, the NGO approach. Partnerships, we cannot do this without building a partnership with the government, and because the health is primarily the responsibility of government, because the government has a health infrastructure. Apart from the BBH and the CSOM, most of the primary healthcare services at the integrated health center are owned by the government. And so the government has the infrastructure, which are equipment and facility. They have medicines and supply, they have the personnel, they are paying for nurses, and doctors that are in these facilities. But the community has also something to bring on the table. And this is about the community and participate in co-management of these facilities to ensure accountability, but can provide resources. There are platforms like Changi, Chong, Fu, Saba, market churches that the community can provide, and the people, labor, transport, communication, and money that the community can provide, and even the knowledge of sociocultural determinants of health that are in the community, and co-financing of the healthcare. And the diaspora is also there to contribute. So the community has something to bring on the table, and having a partnership with the government is important. But there are also need for build partnership outside the government with donors, with other donors. We look at it when in the other way we talk about the humanitarian response and other donors who are outside and how we can build partnership with them. So we need to look at it from the win-win approach. And if we are able to build strong partnership, we do better than just going alone. So empowering communities, here communities need to be empowered. That is not yet the case, because I grew up, I didn't know that. I know that there were health committees, but people will tell me that they are health committees. But if you have seen where health committees work, it's quite different. We are not empowered yet, because the health committees do not have much say about what is happening in the health. For example, if they send a doctor in so and the doctor doesn't come, the community health committee doesn't have to do anything. They just stay. But that shouldn't happen where the health committee is functioning. The community is empowered to do many things and to hold people accountable. Some of the things that the community can do is, if the community has community health workers, they can move from door to door, do awareness raising, and educate people, and provide basic services, and refer people to the health center for things that they cannot do. They can organize health talks, either in the market, churches, villages, square, and Jangi houses. They can go to schools to guide the teachers, so that the teachers can talk to students and pupils in school, basic issues around health. And they can map households and their health needs. Identify, for example, children who need vaccination, pregnant women, and people who are taking medication, and follow up. They can report to the health center on a weekly basis, say on Friday, to report and inform what is going on, and report there and produce their report. They can identify model households. These are households considered excellent. They have proven they're excellent because they have all their children vaccinated. They have everything doing the good way, and they can show them, and they can actually show them as models, good examples of households that need to be there. Then other sectors. Now we need, this is also some of the things, a gap in the primary healthcare, because Cameroon health system is not so integrated that we have the link between different sectors. And there we need to make that link with other sectors. And the community health workers can do that, as well as the health community health committees can also do that, trying to make links with other sectors, like education, where children in school are taught health literacy, and teach families about nutrition, water and sanitation, environmental health. And they can also work in close collaboration with accountables responsible for agriculture. And the health committee can do this link by connecting with the NSODA as in other initiatives outside the health sector, and see how we can make the link and mainstream health into other sectors. So when we say paying for services, there are 5 types of health finance. Just to present it, and then we see where we are going, which model are we going to take. There is the tax base. Tax base is similar to what we have in UK, because in UK, some of the tax that you pay in goods is used for the health, it's used for payment of the health services. And so, but the tax base, the problem with tax base is that you need to have a non-corrupt system where you can actually collect taxes and really put them in the health system. And that is it. There is a social insurance, like the one in France, where payment is deducted from people's salary. But this one, the problem is that at least 80% of the population need to be working in formal employment, so I can able to get money from them and then be able to pay for the health. Then there is a private insurance, like in the US. The problem with this is that many people are not willing to pay, especially when they are not, they don't have enough money. They are not willing to go and contribute to the private insurance in advance. Even when they have money, many are not really willing to do it. So that is another problem. Then there is a community insurance, based insurance, which is like private, but the aim is not to make money. But a way it has been proven is that if community-based insurance is made mandatory or is driven directly by the communities, can work. But there is a fifth one, which is out-of-pocket payment, where you go to a health facility, you pay for your services. And this is the worst type of health because it can plunge the family into poverty. So far, the two types of health finances that have worked in Africa, we have the mandatory payment for health insurance, which is a community-based insurance which the government would like people to pay so that they go to health facility, they have services free. And we have that in Rwanda. Then there is community-driven health insurance, where the community are actually leading and are holding the health system accountable. They are managing it, like in Mali. They pay for it. They are willing to pay because they have the services. And if they don't have the services, they can actually, because there they can tell the government that they don't want this doctor, that is change this doctor, the doctor is not doing good work. And the government will be obliged to change. So they can hold the government or they hold the health system accountable. But it has to come from below, from the community. Community feel that they have the ownership to drive it. Then the L, which is about leadership. Leadership here is about the community health committee, providing leadership for the primary health care at community level. Imagine a situation where all villages and so, they have representatives in community health committee, and that they meet every month and decide how the health center is run. And each health center that has a community health committee with all villages represented, and they sit and decide how the money generated by health center is used. They sit and decide and can even recruit even somebody like a guard or somebody to work in the health care. They can even recruit a nurse. Imagine that type of accountability where we have that control over managing of the health center. We are still far from that. So, but that is what is in the Cameroon health sector strategy. And so it is not something outside. It is already written, it is not happening, but it is written there. So, so imagine that type of situation. Such situation will provide the real leadership for the health system. And in such a case, the different health committees of the health centers can come together in a district federation, and all the districts, let's say in the region, a Northwest region, can come together in the regional federation, and they do meet once in a while to discuss and share experiences between each other. And the last is about essential services. Those essential services include a comprehensive range of services that meet the needs of the population. They meet the needs of at least 90% of the needs of the health needs of the population. And this includes promotive, preventive, curative, rehabilitative, and palliative. And the services span the entire lifespan: children, teen, adults, and elderly. The services are provided both at health facility and the community, through community outreach, through health worker outreach, and all that. Now, that is it, the way the proposal. And so we have the NGO approach. I was thinking we discussed this the couple of meetings with the committee for the executive committee for the Health Rennaisance initiative. And the idea is, how can we make NSODA to be a full NGO? Okay, it's not just the Health Rennaisance initiative, the whole of NSODA to function as an NGO. We had this discussion. The former president was there, Fomig was there, and we talk about this. And he was very excited about this. And he provided some guidance and told us that, in fact, NSODA is an NGO, is regulated like an NGO. But unfortunately, we don't function like an NGO yet. But there are some advantages of functioning like an NGO, because functioning like an NGO, we are able to mobilize more resources. We are able to make it more sustainable. We are able to do bigger things than we can do just by ourselves. If we function just as an association, we depend on the resources that we can contribute. It is just because probably if we are not well informed, we think this is something undoable, but these are things that are doable. So the approach is, if we have to make it an NGO approach, some of the things that we may need to considering is, we need a small team that we're working initially, but probably this small team will be volunteers. I call them full-time, but they could also part-time. But we need people who are really dedicated, who will sacrifice their time to be working for the initiative and participating in meetings, because their meetings have taken place in Yaoundé, I know that. These people will be there and doing some work, and some will be in the field, but some will be in Yaoundé. They need to be people in Yaoundé. We cannot avoid that. They want to make NGO, because that's where we are going to get the money. The money comes from donors, and they are there. And we cannot avoid that not being present there. So if we initially have people who are willing to be volunteers and to take on the initiative, we can train the team. We can train them on different aspects like project management, financial management, proposal writing, fundraising, which communication. We train them on these different things, monitoring and evaluation, that are necessary in order to manage different initiatives. And then they also need some guidance how to follow in order for them to function effectively and to ensure continuity. We need some policies and procedures that they can refer to when they want to do something. They know that the guidance is given, that this is the way they do it, and that is critical for good governance. We also need a website, because we have to raise funding. Sometimes we refer donors to our website. They see what we are doing. This should be, I think, the website of NSODA, not a Health Renaissance, and having a page on the Health Renaissance. So the website of NSODA should be there and has somewhere where we say, for the area of health, these are things that we are doing. And then we need to, why we are doing this, we need to identify quick wins. Because for the NGO to pick up and function strongly, it will need a couple of years. If we start it now, it will need maybe 5 years for it to really pick up and become a full NGO that's running. But while waiting, we need to keep people motivated. We need to do something that will show that we are progressing. So we need to identify quick wins. These are initiatives that we can do in the area of health quickly and get results while we are building long-term business. And so I talk about the phase approach, where I'm thinking that phase one is about the humanitarian. We are in full-fledged humanitarian crisis. So it will be impossible for either of us to do development and purely development activities at this point in time, because some will be impossible. So phase one probably will be about focusing on quick wins to address humanitarian crisis. Humanitarian crisis usually focus on reducing the excess mortality that is caused by humanitarian crisis. Rather than reducing mortality, it will be almost impossible for us to reduce mortality below what was before the crisis. But if we can limit the mortality to the level it was before the crisis, that is our humanitarian response. And then at the point where we see that the crisis is coming to an end, we can combine humanitarian and development. We call that, in technical terms, humanitarian development nexus. So it is building humanitarian into development and all, like the two going together as one, because we need them. It is a transition period. And then there will be a later period where the crisis is completely over, and we can do development activities. So those are the phases I can see. So I mentioned earlier that we need people to participate in humanitarian development partner meetings in Yaoundé. I know that Cameroon is declared, the cluster system has been activated. For those who know humanitarian response, they have what is called clusters. Once cluster system is activated, there is the health cluster, which will be meeting, usually under the WHO, and NGOs working in the area of health participate in the meeting. These are usually monthly meetings that will be taking place in Yaoundé. And it is there that they discuss some funding. It is there that NGOs can combine with other, combine together or combine with the UNA agencies and write joint proposal and submit for funding. It is there that they discuss things that are happening online. It's there that you can sell what you have as an NGO. And so these people will need the business card, because those who are there, they will be participating in this meeting, actually seeing the opportunities that are there, and they can participate and raise funding. There will be a cluster on protection, which is about issues like gender-based violence and online child protection. There will be a cluster on nutrition. There will be a cluster on shelter and all the like. So it depends on the clusters that are there. And that's why we need a team that is not just present in the field and doing the work, but we also need people who will be present in Yaoundé and actually working and lobbying and getting money that will help back to this project to work. So, so we need to build partnership so as to mobilize bigger resources. As we do the quick win, we need to document very well and show our visibility. So communication will be key. We need people, communication specialists, digital communication specialists, that will actually be able to help us showcase what we are doing. And we need to be active in showcasing this, whether it is on Facebook, Twitter, and all the like, to showcase the work that we are doing. And then being very professional, we can help mobilize resources. One thing I know for sure is that donors are looking for partners that have capacity to deliver and they can show results. That's what they're looking. If you have the capacity that you can deliver the work and show results, you will not lack funding. So we need to show that we have capacity, and to show that we need to have some small projects that we have undertaken and shown that we have actually delivered them. And we can sell and say, well, we have done this, but we lack money. If we have much money, we can do this. And I know that the crisis back home, I consider it a neglected crisis, because not enough funding is currently coming in. But I know that there will be a time where the crisis will be taken serious, and a lot of funding will be coming. I've seen that in all crises that happen. Around that time, it will be too late for us to activate around that time. It is now that we are working. The advantage that we have, and NSODA, is that what we can do there, no other NGO can do. No other NGO can be present back home. We have, it is our homeland. We understand it more than any other person, and we are present there. No other NGO from external can come and do the work that we can do. So we have that as an advantage of having access and understanding the culture, that we can demonstrate that we are doing something that no other person can do it rather than us. So it is an opportunity. And the idea, as I said, is to see how we can move NSODA from being an association that is operating and dependent on membership contribution to an NGO that is full-fledged, that can mobilize huge amounts of money, that can help develop the health system and working much more far, so that we can build back better rather than just build back to the way it was before the crisis. So thank you, everyone.
Thank you very much, Prof. Mubiji, you will on mute, but yeah, feel free if you want to come in and maybe comment, or if you have a question, it's open. So for those who joined a little bit late, it was Professor Eugene who was presenting on the NSODA Health Rennaisance Initiative, a roadmap that can help bring much better health in store for tomorrow and generations to come. So please feel free, come in with your comments. You can indicate, maybe if you can indicate by hand, or if not possible, feel free to also speak, unmute and come in and speak. I see we have 23 people. You are still on mute, so I'm sure, please feel free to come in, yeah. Yeah. Yeah, I'm forming you on. Yeah.
Very Kentucky, very with them. Very Thai Eugene very for more this presentation of phone. This is very interesting, very deep, and I like the way forward proposals to say we can achieve more if we register and take an aspect, whether we are taking it from the initiative point of view or joining with the rest of the initiatives, register as an NGO or something of the sort that can then elicit more funding and support from outside. So they're a good idea. As we move forward, we should think about that very clearly. Of course, it begins with health. So for technically, again, we are about how we are looking at the issue of health and liaising it as we look forward in the context of what I am technically the Humanitarian Development Nexus, and I like that very much. The more kilo we focus on peace focus on humanitarian peace and development nexus. The more the peace law galvanizing, more like a bridge bay, like an enabler for that to happen, for us to graduate from that humanitarian into the development effort. So, and again, for the initiatives, we closer the synergies where it comes in there. So, as the Law Beauty Project, I'm quite taking all those into consideration. Once again, very with them, very for this initiative and very with them,
No, very informal. No, Kyoji. Prof, attack comment on that about you.
Yeah, very informal. Mshatyo, very okay. Yeah, yes. More informal young. We also say humanitarian peace development nexus, or simply humanitarian development. I didn't want to confuse people, but to make it so complicated, I just simplify it. But peace is there during that transition period. And just to say, just to clarify the game, okay, the former president, Schuman, he said that NSODA is functioning, can function as an NGO. And in fact, it's an NGO. So we need to ask his advice on this. What I know is that for NGOs in Cameroon, you register as an association. And associations are governed by the same rules as NGO. And then when you work for 2 years, you can apply NGO. But the funding doesn't change. When you are applying for funding, they won't ask whether you are an association or NGO or anything. You have the same status. So what he meant is that NSODA can function right now as an NGO, and we don't need to do anything for it to function as an NGO. Okay. Yeah. But the process of whether it is now the status has moved from association to NGO, we need to clarify with him.
Right. Okay. Good. No, Barry. Okay, yeah, more comments or questions, feel free to come in. Yeah. You know, more people usually unmuted, so. Okay.
So we are looking for your input. This is just initial ideas, especially that we need to get other sectors on board. Okay, so this is not a health issue. The health may be going ahead about the NGO approach, but eventually agriculture will come in, education will come in, and all the like. So and all the other sectors can also come in. Peace can be, the element of peace can come in there, because generally even what we do, peace is very cross-sectional. Many of the things that we do build the foundation for peace, even the health, even agriculture, working with young people, and then women associations and all that. So we need to put all these things together and then build a solid NGO. The challenges I foresee is about getting people who are really committed. But I say there is an opportunity here, because there are people who do not have jobs, but having experience in an NGO can give you experience to get a job. It's like having a placement and building your own experience to really go somewhere far. Okay. Eventually, if NSODA has funding, we will not keep on with volunteers. We will have to pay people, and we have to recruit properly. But in the beginning, the suggestion is to get people who can actually sacrifice their time for NSODA, at the same time building their own personal experience, which they will benefit from in the later on. Okay,
yeah,
they'll benefit from.
Absolutely.
Yeah.
No, absolutely. Yeah, thanks for that, Prof. And then if anyone is listening and is interested, please do let us know. If you want to be part of, committed and be part of this, do let us know. I'm sure many people here in the Rebate Forum, or yeah, you can always reach out. I'm sure if you reach someone who you always get to us. Yeah. Yeah, thank you for Clement. You have your hand up. Coming, please. Yeah.
Thank you very much, Prof. Congratulations for this wonderful presentation. I want to thank President Banjika for organizing this. I'm sorry that I joined late due to other unforeseen circumstances, but I'm so elated. I am so elated with the impetus that Prof has brought into the Health Renaissance initiative. And I think that Prof's entry, being who we all know he is and where he works, his experience will just be, for us, a plug and play kind of thing. Especially in Africa, his experience has not been out of this continent only. So he has a worldwide experience that we can just tap from. So for us to be blessed with that kind of leadership for the health initiative is something that is highly plausible. When I look at the overall objective of the Health Renaissance initiative, like he put it, which is to reduce premature mortality in SOF. I think the first thing, may be to actually evaluate what is the average age at which people die in SOF, for instance. And we realize that critically, a lot of people die due to just negligence and lack of prevention. Cure, hospitals, and all of this, they only come in to do the firefighting. If a lot of focus can be on prevention, primary health care, just simple hygienic procedures and habit, proper, he has mentioned agriculture, which, maybe we'll have time to comment about. You just realize that we live in an area where we have plenty, yet we are washing our bodies, ourselves with spittle. Allah, we did care for have it in abundance, but I the way you structure for only good health and a preventive ayasi. So the fact that the Health Renaissance initiative highlighting the preventive aspect that overlap with other initiatives, I'm sure is going to, bring a lot. Allah, like if I'm more education, Allah, Americans only like early one is for school. I insisted you one why I for you. but I really want to show. So, Bolo Health Renaissance, Education Renaissance Initiative, I insist on education. Schools are showing. They are one year for a very good health for year if I could do. Then he held me for and making sure you want us to no dry acid and in Kiori one. You know, all these things I'm seeing an ecosystem, and that is why most of you must have observed that there is a mute in some of the initiatives because we needed to come into an ecosystem. The as NSODA, one initiative you know, on its own. And I want to salute the initiative that President Banjika took to create, you know, a forum that will now bring all the coordinators of the various initiatives together. And I think health, from what we have observed today, is going to create a financial and coordinated impetus to that leadership. So, Prof, Mtafo Aberu, clearly for your effort and for everything. And this is going to be a blueprint that will help all of us. Very. Nkita, just for our strategy, as thinking or in your vision, what is the place of traditional medicine? You know, knowing that there are areas that we can leverage on, you know, and make sure that those values, those aspects of traditional medicine that can help in the event where you don't have a formal medical setup. How do you intend to integrate that into the vision that you have? Thank you. Very.
Okay. Very fair, Sheikh Clement Union. Very. So, and thank you for the orientation and guidance on this aspect. With you, with the worth of experience in some of these sectors, and I really appreciate. We did discuss the issue of traditional medicine among the executive of the Health Renaissance Initiative. And there were concerns from some people about actually understanding the true and trusted medicine from charlatans, because it is a sector that there are more charlatans than the true people who are doing the right. So, and some of them are actually will cause more harm. So it's an area which is a potential area, and there's a risk there trying to see exactly, we need to figure out exactly how to filter the real and get the real good people doing the good work from those who are real charlatans and playing around and causing more damage. So I think it is something to keep reflecting how we can do that in order to make it work. All right. Yeah.
No, thanks for that, and yeah, thanks for your updates, for Clement. So yeah, President, you have your hand up. You want to come in, and then if you have your other comments, please, you can also show your hand, or after the President, then you can come in. So yeah, Sheikh, come in, please.
Okay, thank you very much. I want to appreciate Prof for this wonderful presentation, and I will just go straight to the point. And where I'm very much going to comment is on what he calls health in all programs. That is something that all initiatives, all committee heads need to underline and take seriously, because that concept means that when any committee is drawing up a project or conceiving a project within the context of NSODA, it should have health as a major pillar. When the sports initiative is conceiving any project, health should be an element to take seriously, even in culture, in education, in every aspect. In other words, when any committee works on a project, it will be imperative that they always turn back to the Health Renaissance Initiative. to paint a picture of what they have in mind so that the Health Renaissance Initiative team can be able to suggest or propose areas where they can insert health concepts so that we can have health in all our programs. That is what that concept is talking about. And the idea of the website is something obvious that we will need to invest a lot of attention in as from now. Otherwise, Prof, thank you very much. And that's principally what I wanted to comment about.
No. Okay, great.
Yep.
Thank you. Yeah, thank you, President. I don't know if I don't see any hand up. If you have a question or a comment, please feel free to jump in case you are not able to show your hand. Yeah. And while doing that, just welcoming every other person that have joined. Yeah, come in, please. Sorry.
Yeah, this is Derek, Vice Chair of the Sport Renaissance Initiative.
Yeah.
I would really like to thank Prof for the presentation. Kita commentation so much about the insurance policy. If I don't give he had like the first, even in Cameroon, I think so. For you really why we are in place, are functioning normally, and then some low layer I more problem more crisis care for Laland. Nearly everything has been affected head-wise. So at the far already the key contributed greatly even for we una young or santa with them. And then why not why you can see we what that present even to the government itself. One more see at the key can you facilitate in your so Prof, really thank you so much for the job well done. Very well.
Okay. No, very Vice Chair. Yeah. So Miana Chair War Sports Share so you need. Yeah, come in, please.
Okay, for the presentation. I would just like to emphasize on a few. The first thing, I'm catching for Prof presentation to the something that has been bothering us in sports. And I remember I talked to the president of the president on the presentation we were preparing to share. But we show up, who are very interesting for me. We have to rethink the NSODA approach. If it really fits in the first initiative approach. Because you realize that NSODA approach, all what we've been doing has been raising monies from members. Independently, as will issue. Let me take, for example, agriculture. When you look at the rich document that agriculture produce, and you look at the implementation, you start understanding that implementing agriculture.
They don't kill them, no, yes. Who's back?
It's just a dream. So that approach of I think the sustainable way, coming in through NGO or through social enterprise, something will need completely a different reflection within the NSODA organization. And something we really need to look at it, because when you come back to sports, few key members of sports actually saw that sport was you can really show Tiamba. I bet you in 2-3 meetings you will not get any member. It's not because people don't want to raise the money. It's because how sustainable is that strategy when it comes to sports? So rethinking the NSODA strategy. Or follow initiatives here. Something of executive and elders of that of the NSODA care for thinking how do we want to move so further? We want to move so ahead. Yes, we can still do that. How sustainable is that approach? Also, with that approach, can you really go out there and look for money? So that you really go out there and raise projects and look for money. When you come to sport, one of the challenge of a security and the limiting sports a culture. You can look at sports from a community. And a community in that sense, no lay more for Labiam Dom sports you do very fast. Race from Bamsimosi. While there are subdivision, the geographic zone. Don't talk of it as a community. Because sports from the onset, when you start going on tribal lines, it becomes difficult for you to raise the required funds at certain objectives. So another thing, don't care for second thing, we really have. I'm so happy if I came up as the non-SODA KKNU. Don't care for from to our road. Now, some discourse here at the calendar at the level of initiative. A lot of brainstorming, a lot of ideas, like the Prof is presenting with. They're very wonderful. If our route, if the linkage, the upper part also the up or the real put on the ground. All these ideas don't thinking they are Zoom meetings for over 2 years. It's high time so that lady, how do we get down to the roads? The true you know it's the village development association in different towns where must hold it. How do we start getting through those areas to bring it down to the roads? I will beg to stop it there. So my message directly.
No. Thanks very much for your comments, Shay. So you, sorry, yeah, should definitely. Most of some of the chairs, where some of them have held of the different initiatives, Adjafen and more President Janfen, definitely, and also more the VP as well, Janfen. Those are things that will be taken in. I think, but just to comment, also it was actually realized that. Because when we were talking with Formi, the former president, the point is we need to start from somewhere. So it was quite understanding that having people contribute all the time is not sustainable. But to show in any organization that you can deliver, you need to have something like, what have you done already, right? So we're trying to gather up some of the things that we have been able to successfully deliver. If we can package that, then maybe, and I think that's what Prof was also insisting, that it's good we start now, so that when the time arrives, we then have what we can show for. So that will be part of that packaging. I think maybe another comment will come in before, if there is something that Prof will want to comment on, then that's fine. I noticed, George, you've had your hand up for some time. And then after that, we hear from Fon Kong and yeah. So George, come in, please.
Shati, especially Prof. George from Sumner from Douala. The point I wanted to probably add more spice on it is the issue of relating to health and peace. When we talk about health, considering the fact that we are now looking in opening our community to the outside world, this issue of health and peace, a major preoccupation for if we want to go out and do partnership, especially partnership of going above our borders and going to international level. The issue of health, health, safety, and environment. Health, safety, and environment. These are the aspects that lead to good health. And alole vinyo we yasive janen we really we jakata investing bamself and to me the aspect of health say impact ya onelia they allow do peace versus soon about security. It is so unfortunate the event we are called was beef for incident we allow chasing away investors and he drag it on for long. We reload the Java, we wire themselves more. We sponsor some of the big projects and allowed to be on Yata in a security assessment report to see the threat level. I'm going with why why some billions, we limit 10 to 20 years or 30 years for carrying bam. What is the possibility that Rostimose or Kongnyuy for security learning lambo carrying bam? So those assessments are very, very, very important. So person lo dulenjawa do into partnership for level also for level Cameroon at outsider. Kimna nendiji wasana kera section version our drag tabin just more Prof yongnya Eugene Kongnyuy amanale aspect of kimna the good idea the sector wasan kusi care experience. So mina verify idea that good. That's referring to CPI.
No, verify. Prof. Any comments to make before from Kongnyuy as a P comment? Okay, yeah.
Okay. No, verify. Ma very with the most very for the wonderful contribution. I on yeji we took a push on this together, then I'm certain that we are going to really transform our objective. Our objective is to transform the SOR. There are some of the things that I will want to actually add, which I didn't mention. Just to say, in terms of donors, we do have the donor community is divided. There are donors that only donate to crisis during humanitarian. There are donors who only donate to development. That gap is still there and is not yet covered. So even during crisis, with all these things that are happening, when the message will come across the donor community that this is a neglected crisis and we need to actually respond to the crisis, you will see a lot of money coming in from the donors who donate money to humanitarian. And then those who are donating money to development will be waiting until the time that there is peace and everything is, they say the crisis is over. Then they will be pumping their money. They say, we don't want risk, we don't want to go. So there is that divide. The second thing that I also want to mention, which is critical, is that our capacity to mobilize resources will depend on our capacity to deliver. How we show. I am very confident that if we are able to show that we deliver something small and give results, we'll be able to mobilize money, resources. And that is why we are discussing in the last meeting, I said, for all the other events, initiate things that we have done in the area of health, let us document it and then show the results. And then anything that we will now plan, I bet you it is important that we plan very well to demonstrate the impact on the population and show that we are saving lives, because that is what we said. We can show to donors that, look, with small amount of money, this is what we have delivered. If we have bigger amount of money, we deliver more. That is what they want to hear. They don't want to give money and then it goes into water. The third thing is that the team that will be involved need to be really competent in sense that in managing the projects and understanding the ethics and issues around it, because they should understand how the donors are very keen with the money. The issues are not aligned, and they need transparency. They need to be rigorous in the way we manage it. And because if we fail that aspect, everything goes. Donor doesn't want to give money and then come back and it's not very clear where the money goes on. It's very, very critical about it. And that's why I said people who take the initiative, they need to be well trained so they understand their rule, understand the need for openness, transparency, proper reporting, and communication of what we are doing. And then I like what the president mentioned about the link to other sectors. I really call for this. It is important for everyone in all other sectors to see how you can integrate health. If we take culture, for example, we have good culture, but there are some cultural practices that actually are against the health, that actually bring the health back. We have to identify them. So there is a majority of culture is good, but there are certain things, and the discussing with the health can identify those things, those practices that we need to actually eliminate. The same thing like sports. Sports, why it is for peace, is an opportunity to actually promote health, pass messages. So we need to develop those messages that we can communicate during sport and help people understand. The environment is key. Is both the environment, health affect the environment affect health. So we need to link the two. And technology, we don't mention. We have talked about developing website, but we can have apps, we can have other things. We are now in the technology world, so we can't avoid linking the two. Agriculture is the same. The problem, there are issues with agriculture, and so, for example, I now know that our diet is heavily carbohydrate. And for those who are not very physically active, it is a problem. So we have to be aware of that. If you are working in the farm and all that, there is no problem. But you take heavy carbohydrate diet, which you are not doing any active work, then later on you will start having problems. And so we need to educate people and let them understand all this. Water and sanitation, social enterprise. The only way health will improve in the long term if when the purchasing power of people increases. So social enterprise that enable people to have, whether it is agriculture, enable people to have something they can sell, they can make money, will eventually in the long run improve health because they will have the resources. So all those things are linked. And I'm happy that we're working with all of them together because they are all completely linked together. So thank you.
Great. Thanks again, Prof. I think let's take the next set of speakers. I think 3 people, questions or comments. From Kongnyuy, we'll start. After that, we'll have Kongnyuy Team B and then Shay from Gem. Masapi, I think you are still there. Your hand was up, so you also come and let's hear from them. Then we'll continue. Yeah, from Kong, come in.
Well, very President Ban. In back very Professor Eugene. For Kiswin Kyo Sunin na more we have the KFA do can I be decided the President General wasn't shaded for Kunarin. I'm get for a young yeji very shaded for young I initiative I KFA them together. Before more person carrying the necessary initiative. For example, like culture. I mean, some of the diseases and so on. Because of the poor cultural practices. More Professor Eugene. When more Ali, for example, and say the community doing chenkira. You see, we more you lot of for out for phone labo KFC. You lot do for we lot from Bangansu skin disease because of our poor cultural practices. I do want some young health part of culture. I do talent culture. Hand washing me a big problem. Alarm and team in draft with them swap on for free. We will more caruman or doing lawn. I see. So after the live in your cultures and one of the things we have to promote proper hand hygiene. Before more more in the US. Just with the coming of COVID, people here have seen that diseases, seasonal diseases like the flu, the rate has decreased by almost 50%. And the reason is a lot of people are practicing proper hand hygiene because of the COVID. I see them over here, I am in a hospital because they are fluid.
they often dry any kid more fucking Q yasive or covered when we mean you yasive show you didn't be because the rate of the prevalence is very, very little. And so mostly Adam Young almost the entire winter season. You're in a patient about up to 2 bacterial flu. There is a disease or we had a major problem with. And the only solution is just proper hand hygiene. I've seen Menale careful integrating all these initiatives, culture, more tardom Eugene Kasuyoman. There are so many cultural aspects of SOC that are big risk takers. There's a lot of risk taking in those cultural aspects. How can we really modernize or eliminate those cultural practices that promote unnecessary risk? You can say more HIV we so the major rate of spread you order through sex, either using blade. We la dunga sheba who using a blade, you should wear also show who can yield the same blade, you should not show. Are you with your blade? Our clinicians show it tough. You will show in this the same medicine can you show. Those are unnecessary cultural practices where more out of Sunday through education as I've said Sangandea, ba Chenti, new way so yeah. And Mark was young about donors. One of the things they've sent in the pilot phase in our project, they've seen the COVID mask project, documented very well. The education project in the initial project, more been to demonstrate that you are capable of doing something. But in case you work with them, at Thomas more project version, so that when we go out to solicit for funding, we should be able to tell them that we manage this project at a micro level, and it was very successful because through the management of this little project, we are going to learn so many things. We are going to be able to see how we can be transparent, we can be accountable, and we can even know the people that are good people in the ground that we can rely on. I can find kita for Jimbaku to say verify.
No, verify from Kong. Then new team be comment, please.
Okay, Mr. Wirado. Very Dr. Eugene, very okay for phone. Very urban coordinating. Nkuta for contribution. I reckon link herbal and traditional medicine medication. I just have 2 things that I can propose that I think might be helpful, especially since we are also talking about an eventual website. I think since Dr. Eugene mentioned about a community approach, if we go to communities especially going towards the villages, we would know that most of them tend to depend on this traditional and herbal medication for first approaches, first response to medical situations. So I think it will be very helpful if we can implement an approach that helps us to be able to vet to separate the quacks, traditional and herbal practitioners from those who are really doing the real work. I think having a community approach where people can go to villages and talk to the people who interact with these people, because a community opinion of somebody is not very scientific, but if people have the general opinion that this person is helpful, that's information that can be helpful to put on a website and somehow vet some of these people who people can go to for certain type of problems, especially not generally, but know that if you have this type of problems, you can go to so and so people. And I think it will be also very nice for the health initiative to set up a sort of KPIs or things that they can use in a somewhat now quasi-scientific approach to be able to vet people. Like, these are the things that we use. We'll use this point, we'll use these things as metrics to say, okay, this is somebody who is at least trustworthy on so and so subjects, or they can help on these areas. Yeah, so I would mention having KPIs or metrics to be able to vet herbal practitioners, use a community-based approach to visit people who interact with these people on a normal daily basis and be able to get information. Who do you go to and really get help? And then it will also be very good to have, to be thinking forward, like somebody also mentioned here, that in this phase, we may not be able to do a lot, but there are things that we can do while the crisis is still going on. I think one of them could be possible to start putting together traditional herbs and plants that are helpful for certain type of conditions and make this information on that website, somewhere public where people can access and know that, okay, these type of plants are good for so-so and so-so response, or just take them constantly to avoid so-so and so-so problems. Education has been mentioned. All of those things tie together. I think all of these things is connected. So yeah, those are my 3 points. Kind of a herbal repository of plants. We have a lot of them, and so that are very, very good for health. Those that are preemptive, those that are reactive, like when you already have a condition, what can you go for? Be able to vet herbal practitioners and doctors using a quasi-scientific approach and also a community-based approach. Yes, those would be my suggestions.
Thanks so much for those. I think let's take the last person, then Prof will comment again before. Shay von Jem, please come in. Sorry. Shay von Jem, you have not, you are still on mute. You need to unmute. Okay, and let me see. While waiting, Masa P, do you want to come in? If you, yes, go ahead, please, Masa P.
Yeah, good evening, everyone.
Good evening. Sorry, we cannot hear you well. There's some background noise. Oh, I don't know if it's the wind.
Okay, I just want to give a general remark.
Okay, go ahead. Yeah. Yes, it's a bit, there's some noise disturbing, but just try. Let's see if we can capture it. Yeah.
Okay, I wanted to talk about Lamso, our language, because when I listen to speakers, I hear English. Even when somebody wants to speak in Lamso, he mixes it with English and he doesn't. I think that
Sorry, Masa P. Unfortunately, I can't hear you. I don't know. I hope I'm not the only one. I cannot hear you very well. It's fainting. I only hear some words, but then it's disappearing. Can you try? Maybe change the position and come closer to the mic. Either it's the wind or something. Sorry about that. I think. Let's see if Masa P. What Masa P? While you are changing your position, let's allow. I see Shay von Jem. You are on mute now. Do you want to come in, please?
Very.
Okay. Yeah.
Mashati wisdom. Suji Madai follow the presentation of Prof. Eugene, but are very rich and interesting. So the only observation of kita for you could more recently ada NSODA wa asada wana ba limo an NGO. So a Prof could explain ke jong young more ada create a small team of volunteers rather than dedicated. Where I'm more based in Yaoundé. I'm more field. So I can go Swiss for some carry funding from the donors, be it a humanitarian or development. So but some need lobbying. A lobbying when Reka without doing okay for you lobbying, maybe through the UN agencies or the donors. And at this lobbying, I'm not the finance. Be more NSODA. Our main source of revenue, just the package on bank on registration fees. But I do admit at the level of lobbying here, I was lobbying for career funding. More thinking more Cameroon run. Kim Nanidia Tambo would have done if I wasn't carry the funding. I'm not too far in advance. So I'm in that case, as I was saying earlier, Simon Senor Carol and any finances now for adolescent that lobbying show. So at the main word carry, adolescent carry very good projects, but at the level of lobbying, it's not impossible for some succeed for carry the funding. Very actually
Okay. Imati Prof, just comment on those. Then after that, Masapi will try again after the comments from Prof, and then slowly we'll move to hear from the updates from the Education Renaissance Initiative. So yeah, Prof, go ahead, comment.
No, very Shea Fonjem, Francis, and Nyechimbi. Just to start with the this last question on about lobbying and having the funding. Where I think that we will need funding, it is about helping these people have a small office. We discuss about it, and maybe their transport to go to these meetings. Normally, donors or any person do not ask money. If they are asking money, it is bribery. They don't ask money for you to give you funding. So it will be bribery. And I know that the type of bribery that will happen, and I've seen that happen, is when somebody wants a bribe, he will tell you that I will give you money and you'll give me this amount back. That is about bribery. So generally, they won't ask you to give money when you are lobbying. Lobbying is because I won't use the word lobbying because sorry, someone is speaking.
No,
I would
continue.
Yeah, I won't use the word maybe lobbying because lobbying usually will happen when in around parliaments where we are doing things around, where there's advocacy and all that. But in this case, usually what will happen, the classical case, what will happen is that you are attending cluster meetings, the health cluster meetings. There are other different clusters. There's the WASH cluster, which is water and sanitation. There's a food security cluster. There are different clusters that are meeting every month. And so we need to be aware of these clusters. Sometime during cluster, and there's a pool fund, which will announce that they are going to be funding something on hand and tell where the money is going. And then what will happen usually is that either you as an NGO submit your proposal alone, but usually they will come together, 2 or 3 organizations will come together and write a proposal and submit together. Or another donor say they have money. It could be the UK, it could be the US, say they have this money. And then you look for other partners and you come together and submit the proposal. If it is of good quality and you have good track record, then you get the funding. So most of the things that I will see that we need money, I don't anticipate that we're giving money if somebody asks. If somebody asks money, that give money to give money, that is a thief. It's not, I wouldn't advise that somebody should give money to somebody, that it will be a spam who will just get your money and go away. So I wouldn't advise us giving money for somebody who is asking money in order to give us money. That is not the practice. Now, concerning traditional medicine, I like what the proposal from Nyechimbi. I think it's a good proposal to explore. I had thought about the option because we do have herbal plant experts in-house. We do have people. They may not be, they may be in different countries, but I know we have experts who have studied herbal plants. So they can also help us identify the herbal plants that are in soil. And we can link those herbal plants to the traditional doctors that are in soil, because we do know those plants and what they are serving, what type of diseases they do treat. And making that linkage, we can also help us in addition to what the interviews that the surveys that we have in community to identify those who are doing the good work. We can also use those the herbal plant. So if it is purely traditional medicine using herbal plant, I think it is not, it will not be a big problem. Where we see a big problem is when there are soothsayers who forecast. It will go into a gray area where we have doctors who are not trained in telling about the spirits, and somebody who has the idea of seeing what the spirits are doing. And so we come to a gray area. We cannot really assess and understand whether this is true or not, and all that, and become very complicated. And he's telling you that you have this illness because it is caused by your uncle and all that, and become very difficult. Before that type of situation, I think that is where we need to reflect what we are going to do, because we are completely in two different worlds. One world of the medical world that doesn't understand that language, and then this person coming and he has to understand the language. You understand? So that's where I see problem.
Okay. No, thanks so much, Prof. Let's have Basa P, if you can make your comments. I know that we've really taken some time to have comments, but we appreciate them because that's why we're having this. The conversation will continue, and if there's someone who, after listening to this, you want to join the Health Resistance Initiative, please, you can indicate, and we can, especially some very nice comments that have come in, we can then have you in that. The initiatives also have their own meetings separately from this. Then we can then continue that conversation there. This was just more of like show to the general public what we have. So Masapi, you are the last person to come in, and then maybe we'll hear from, we just get some updates from education. Masapi, is it possible to try again?